So a very good evening to all of you, and myself, Dr. Neeraj, and I'm going to take this class for all those EDIC 2 participants. And basically, this class is for obstetric emergencies. So we'll be discussing the clinical case scenarios, and there are lots of meanwhile, because it's a regular class, so I will be not examining you all, but just few rules before I start this class is that please kindly mute yourself. If you have any questions, that you can ask directly the writing in the chat box. And if you want to ask any problem in between that you're not going to get understand all those things that what I'm discussing, so for that you can definitely unmute yourself and you can ask the question. And because this is the class in which I will be discussing few scenarios. So the domain is obstetric emergencies. So here is a case scenario. So this is how we used to take exams for all those EDIC two participants who are going to appear for the exam. So the scenario will be like this: a healthy 28-year-old G2 P1 admitted to labor and delivery at 28 weeks of gestation, complaining of severe headache and blurred vision. So these are the two important findings that this patient is having. And then after that, her blood pressure was in a range of 200 by 110 with 2 plus proteinuria on urine analysis. And then again, the repeat blood pressure was taken and it was showing 160 by 110. So next reading was 160 by 110. And the lab parameters has showed a normal hematocrit, a normal platelet count, and the normal liver transaminase level. So all those lab parameters was almost normal. So on taking the vital signs, the blood pressure was 180, 110. The heart rate was 123. The patient was not very tachypnic. It was only 25. She was taking 25 breaths per minute. The temperature was 34.2 and she was maintaining a good oxygen saturation of 98. On doing a quick physical examination, the patient was not having any pallor or icterus. Only that what has been noticed was the swelling of the hand and face. And on CNS finding, the patient was repeatedly complaining of blurred vision and then severe headache. And on lab examination, based on the routine examination of urine, on 24-hour urine sample, the protein was more than 300 milligram. So this is overall findings. So based on that, I can ask in the real exam that how will you define preeclampsia and severe preeclampsia? Then you have to enumerate few of the appropriate laboratory investigations that are necessary to establish the severity of the preeclampsia, and then how this patient has to be delivered and how she will be going to get managed, whether you will do a expectant management in this patient or you will be going to deliver this patient. If in between the patient will have a convulsion, so what will be the cause of convulsion in third trimester of or in puerperium, because many of these patients land up into from preeclampsia to eclampsia. So potential causes for that convulsion has to be maybe asked in your examination. And then what are the agents that you will be solely take care or you will be solely going to avoid in managing the hypertension in this preeclamptic patient. So these are 5 sets of questions that may be asked in your exam, although every time the scenario is going to get changed. So the answer, you have to know the definition, and the definition should be very precise. The value should be very precise, like SBP more than 140 and diastolic more than 90, and there must be 2 cardinal features like proteinuria should be there. So these are all findings which is showing that the patient is having a sustained hypertension, making your diagnosis as a preeclampsia. Okay, now coming to the next part. If the patient will have a systolic blood pressure of more than 160 with a diastolic of 110 on at least two occasions, and at least 2 hours apart, with all those, any of these findings, then you can label this patient as a severe preeclampsia. So then you have to understand that what is the proteinuria that is coming in that urine, whether it is 300 milligram or it has crossed more than 5 grams, whether the patient is having oliguria in less than 24 hours, the urine pouring is only less than 500, the patient have a elevated serum creatinine values or some sorts of edema, or patient that headache is now going to get a persistent one, the patient is now going to getting a persistent visual disturbances, the patient throwing some seizures. The patient will now started complaining of right upper quadrant pain, as well as along with a elevated liver function test or liver function test. Then the patient may have some derangements in the coagulation profiles like thrombocytopenia, or the patient will have a decreased amniotic fluid leading to your oligohydramnios, or there may be some IGR type of thing or placental abruptions. So this is in nutshell overall the problem with these patients. If you're going to diagnose these patients as a severe preeclampsia, like you have to tell these definitions, that how a patient will have a preeclampsia and how the preeclampsia is defined and how a severe preeclampsia is going to get defined. So all these finding, at least in many of the exam, what I saw that few of the students spoke few of the students tell all these sequences and many of them miss. So that has to be remembered. Okay. Now coming to the next part is laboratory investigation that are necessary to assess the severity. So which laboratory or which lab investigation is very, very important for labeling the severity of the preeclampsia. Now for this, you have to answer in this order only. Like it has to be CBC. Why? Because I want to exclude the coagulation defect like platelet count. I want to check platelet count. Sir, I want to see the blood urea nitrogen, whether there is any uremic symptoms in this patient, or whether the patient is presenting with a very high serum creatinine, or the patient is having some form of acute kidney injury events, or whether the patient is showing some transaminitis or high bilirubin, deranged coagulation profile. So I will go with many of these students miss this part. Blood typing and antibody screening. This is very important. They used to tell all those three findings, but they missed this. So here the blood typing, grouping typing, as well as antibody screening is very important because of the your RH incompatibility that has to become in your mind, and you have to think like that. And then 24 hours urine collection, of course, that is again very important. Now, again, the question was that what were the potential causes of convulsion in this third trimester of perineum? So if you'll see that convulsion during this specific third trimester or if a patient has delivered a baby and then she's having a seizure, so until proved otherwise, you have to think of these two causes. Now, what in the real exam, what the problems with the students is that they used to tell this cause very commonly: hypoglycemia, first cause; intracerebral hemorrhage, definitely; and third, this cause they used to miss. So this is your until prove otherwise. If the eclampsia is there, so epilepsy is, the patient is already having some history of epilepsy background or in the previous history, but CST, cerebral venous sinus thrombosis, ICH, intracerebral hemorrhage, and hypoglycemia. So these are the three until prove otherwise the cause for the seizures in the late or early purpurium or in the late trimester of the pregnancy. Now, next point is what agents that you should avoid here in these groups of patients for managing severe hypertension. So this is again the very specific list with all explanation that in your exam you have to explain at least. Okay, sir, I will be thinking of ACE inhibitors and ARB2, but the problem is that in the management, because it can lead to neonatal renal failure, and it has more delayed onset of action. It takes around 1 to 4 hours to act. So I think ARB and ACE inhibitor has to be avoided in these groups of subsets of populations for managing your blood pressure. But even what about the nifedipine? So what is school of thought nifedipine says that nifedipine, if you are using nifedipine in conjunction with magnesium sulfate, because many of these patients requiring a magnesium sulfate infusions also, considering these patients as a eclampsia, because the seizure is also very predominant. So the co-administration of nifedipine along with magnesium sulfate is not very much advised, because it has an exaggerated hypotensive response. So that has to be remembered in your mind also. Many of the time, student used to tell that we'll use that nifedipine for managing these patients. IV nifedipine can be used or oral nifedipine can be used, but if the patient is on magnesium sulfate, you have to avoid that. So commonly used drug for these acute settings for managing is definitely first choice is Hydrala, then your labetalol, and then your nicardipine, and then only the last choice is nifedipine only when if magnesium sulfate is not given concomitantly. So these are the things that you have to remember. Now coming to the next vignette, the similar case. Now we have managed this severe preeclampsia. And now after 1 week of preeclampsia, now she started complaining of abdominal pain. Now she was having abdomen pain with some associated nausea, but her blood pressure was normalized by using all those drugs that what I have discussed right now. But peripheral blood smear shows few helmet cells and few burr cells. So if you can very well appreciate this, how a helmet cells look like. So this is your helmet cell. This is your again. I think this is again helmet cells, and few of them are cystocytes. So these are basically cystocytes, which is also known as helmet cells. So on peripheral blood smear, so these two were seen, and then the patient was having a increase AST and increase ALT. The haptoglobulin level was reduced in this patient. So again, it's a hint that serum haptoglobulin is going down. So what probably differential diagnosis that you will think in this patient? And then the serum bilirubin was very high, and the platelet was again in going to a downtrend. Although it was not very low, but it was below 80,000, 88,000. Now the questions. So there are again 5 sets of questions that we used to ask in our exam when the your student will be there. So first I will, because this is going towards, you have to appropriately think of the diagnosis that this is basically a HELP syndrome, because hemolysis is there and the patient is having a elevated liver enzymes and low platelet. So now based on these questions, what diagnostic criteria that you use for differentiating a patient for a HELP syndrome, and can you classify the HELP syndrome? What are the 2 most commonly used classifications that is used for the diagnosis of HELP as a diagnostic criteria? Now, again, here the problem is many of the people used to tell one diagnosis, but the second one is mostly missed. And then what are the 5 differential diagnoses? Many of them students used to tell 3 differential diagnoses, not all 5. And then what are the complications? Many of them used to tell. And how will you manage HELP? Again, this is again very important topic. And then what is the role of systemic steroids in managing the HELP syndrome? And then what are the indications of cesarean section cells in HELP syndrome? So just see one by one what are the answers. The first is your Mississippi classification. The higher the classification means, if the classification is 1, the severity of HELP is very, very high. If the classification is 3, the severity of the HELP is very, very low. So it is more severe HELP, it is less severe HELP. And why? Because the platelet is less than 50, the AST/ALT is almost more than 70 international per liter, and LDH is almost equal to 600. So here, these both findings are equal in all 3 groups of patients. Only the problems, differentiation in Mississippi is based on the platelet count. So platelet has got too much of importance. The second classification is Tenney's classification. Here you have a 2 classification, like partial or a true or complete Tenney's classification. So how will you define true or complete? If the platelet is less than 1 lakh, if ASD is more than 70, it is just like if ASD more than 70 and if LDH is more than 600. So if platelet is less than 1 lakh, so it is Tenney's true type classification. So Tenney's partial, if the patient is presenting with severe preeclampsia with any of the following, like the patient will have elevated liver function, the patient will have a like absence of low platelets, or the patient will have a absence of hemolysis or very low platelets, or patient will have a low that hemolysis. So based on that, this is classified.